At this year's meeting in the BSH, there were several MPN presentations. One of them was a Meet the Expert session where there was an open discussion actually with kind of live debate coming from the audience about what they wanted to discuss about difficult scenarios in MPN. So interesting, the spectrum of things that were discussed, and a lot of it focused actually upon diagnostics, and a particular area that we're interested in the UK at the moment is patients who have a borderline high platelet count, less than 600 but more than 450, where we don't have a driver mutation. What do we do next? Do we do a bone marrow? Do we do extra molecular sequencing? And then how do we actually follow up those patients? So it was a really great discussion, and for the most part the consensus was it's good to do a bone marrow to exclude an MPN, but we need to do some more work to understand, how good is the bone marrow at actually reporting that? Are we exposing a patient to an additional test? A second area which we focused on is an area that I know that colleagues find difficult, is also how to investigate and manage patients with a high haemoglobin, especially those that don't have a JAK2 mutation or have a normal EPO level. And I think it's really important to clearly in that situation do a very thorough history and examination, including imaging of the abdomen and the chest, but then to be really clear that you can reassure colleagues that if the patient has got a normal EPO level or a high EPO level and doesn't have a JAK2 mutation, either exon 14 or 12, they are extremely unlikely to have polycythemia vera. And finally, we also discuss sort of nuances of other aspects of care that are particularly problematic. So one, patients with a big thrombosis and a very low level JAK2, what do we do about that? They've got normal blood count. So a common scenario in the past would have been patients with a splanchnic vein thrombosis and a JAK2 positivity, but now more and more centres are finding patients with other venous or arterial events. So a lot of very healthy discussion. No clear evidence for practice, but obviously you definitely need aspirin or anticoagulation. And then finally, we also discussed pregnancy and how to manage pregnancy, and around a particular scenario from a colleague of a patient with recurrent miscarriages, and thinking about when to use low molecular weight heparin and when to use pegylated interferon.